Hello, everyone, and welcome back to BackTable Urology Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Jose Oche Silva as your host this week, and I'm very excited to introduce our guest today, Dr. Jonathan Clavell. Dr. Clavell is a men's health specialist and assistant professor of urology for UT Houston. He did urology residency at UT Houston, then did a fellowship in sexual medicine, andrology, and prosthetic urology at the same institution and at MD Anderson Cancer Center. So, Jonathan, how you doing?
I'm doing great, man. How are you? It's been a long time.
It is. It has been a long time. We did recently. Was it for Boston Scientific for Resume? Just a talk about, our experience with those products. And it was good to get in touch with you.
Definitely. And I still remember when I was a intern. I was doing a preliminary year in general surgery back in Puerto Rico. You were a chief resident, and yeah, we had good times back then.
Yeah. So you did one year there, and then you got the opportunity to go to UT Houston, and you did. So talk to us about how was that you enter the sexual medicine world? Was it something you were thinking about before residency, or it was while you were in residency that you fall in love with this?
I think it would be a little bit creepy if I told you that that I went into urology thinking that I wanted to be messing with penises all the time.
True.
But you probably don't know this, but I mean, the very first case I saw when I was doing my sub-I in urology as a medical student was a radical cystectomy with an ileal conduit, and you were doing that with Manuel Omar and Dr. Puras. I thought it was really cool to create a bladder out of a piece of bowel. I'm like, I want to do that. But then during residency, I was actually more into endourology and peds. I loved my, stone cases. I loved, doing my rotation here at Texas Children's. However, most of my research was actually on penile rehab after prostate cancer treatment. So that's how I was basically exposed to the sexual medicine world. Out of that, I was given an opportunity to go to a prosthetics cadaver course at the SMSNA, which is the Sexual Medicine Society, for those that don't know. And it actually that society provides a course for residents to be working on cadavers with prosthetic experts. And I was a PGY4 at the time, and the meeting was in Scottsdale, and there learning about what others did in the sexual medicine world, and seeing the passion in which other sex med experts spoke and gave their presentations. That's when I knew that this specialty was for me. And it's crazy how things work, because this year's meeting is going to be in Scottsdale. We're finally going to be able to be there present, and they actually invited me to give a presentation on how to manage complications related to prosthetics. So
that's awesome, and congratulations on your work.
Thank you.
You definitely have been, working for this and putting yourself out and just, living the life of a men's health specialist in that sense. So Jonathan, how's your week? Talk to us about how a week of a men's health specialist looks like.
Yeah, I've been really fortunate to be able to build my practice around men's health. Like right now, 95% of what I do is men's health related, be it erectile dysfunction, Peyronie's disease, low testosterone, BPH, circumcisions, vasectomies. And we also do a little bit of cosmetics on the side, which that will be an entire different show.
Exactly.
But
we will.
In terms of the weekly schedule, I have 3 clinic days, usually Mondays, Thursdays, and Fridays. I'm in clinic all day from 8:30 to 5. Then up until maybe like 6 months ago, I was only doing 1 day in the OR, which was Wednesdays. And probably around September or October of 2020, like my numbers ramped up exponentially, and I had to add a second day. So now I'm operating both Tuesdays and Wednesdays, and occasionally I can squeeze in an outpatient case early in the morning prior to going to clinic if I need to. And then in the afternoons, it's just trying to grind and try to find ways to attract more patients to our practice. My practice is very different from most urologists. Like most urologists, you have referrals from a lot of primary care doctors, cardiologists, or even partners in your field. I mean, right now in my office, it's only two of us. And the other guy who's with me, he's also a high volume prosthetic surgeon. So I had to find ways in order for me to attract patients. And I've been able to do that basically through marketing.
Marketing. I see also you have a YouTube channel. You go to radio. So how did you start it doing that process, market yourself and to compete in a big city like Houston?
Yeah, I mean, for that, I mean, I could tell you it would be two words: sweat and grind. I mean, when I finished my fellowship, and I had to stay here in Houston. My wife is a dermatologist, so I had to stay here in Houston at least for a couple of years. And I told my wife, if I'm going to develop my practice here, we're just going to stay. And she loves it here as well, so it was great. But anyways, coming out of fellowship, I joined, believe it or not, the highest prosthetic surgeon in the city. So he had many patients who came in to see him. So I felt the need to create a name for myself early on. I couldn't be a Robin when there's a Batman in the office, right? So, so I did everything I could to market myself. I started knocking on doors and, here in our building to let other doctors know I was here. I created a website for myself. My partner was kind enough to allow me to do that. He's like, hey, you need to, if you really want to do this, you have to, create a name for yourself. So I, created my website. I started creating my own content in order to, because again, if you go with these web developers, they're going to create the same website for everyone. So in order for me to differentiate myself, I had to create content for myself. Then I started going to social media, created a Facebook page, Instagram, YouTube has been great, and then the radio show because we're here. I'm here in Houston. Half of the population speaks Spanish, and nobody was targeting that population. So. I was fortunate enough to get into the radio in a Spanish station, and everything has been booming since.
Good. So being a right place at the right time and definitely sweating it, doing the work and just grinding it.
That's right.
And that's, I mean, some young urologists, I mean, one thing is going to a academic setting that you're sitting there waiting for the practice. You have your own steady salary, but if you're going to go into private practice, you need to do that. And you cannot just be on the chair and just wait. You need to definitely grind it and work for those patients.
That is correct. And I actually, I was hearing to a previous podcast from BackTable Urology, and I heard your story that you started paging yourself. You started paging yourself in the hospital.
So you remember Dr. Marcel Walker? So he was the one that gave me the idea, and definitely I did it. And people start hearing my name. So
that's correct. And that's what you need. I mean, you need people to know that you're here, because otherwise people won't know. People, I mean, especially if you're starting out, practice, people won't even respect you initially. I mean, you're the new guy out. People will still see you as a resident, especially if you're in a big hospital with, a lot of, attendings around. And here in my hospital, for example, there's 3 older urologists, and nobody was going to start, consulting you when you're, straight out of training.
Exactly.
So I had to, quickly create a name for myself, and even among urologists. I mean, I started calling urologists and started, telling them, like, hey, I know you don't want to talk to guys about erectile dysfunction, because it will consume 20 or 30 minutes out of your out of the appointment.
That's great.
So just, send those over to me. I'm happy to have that conversation with them. Same thing with endocrinologists. All those guys have all their patients have diabetes. Half of those guys are going to have ED. Same thing with cardiologists, cancer specialists, and that's how you're going to, be able to create a name for yourself.
So you get the patient to the office. He has ED. Let's say a naive patient, he hasn't been on any medication or anything. How's the process? Do you do a CHIM score? How do you evaluate that patient?
So every single new patient, if you're a guy coming into our office, you're gonna fill out a CHIM score. And of course, I mean, if you have a guy who has a CHIM score of 22 to 25, you're not even gonna bring up the conversation. But for everybody below that 22, I'll start asking them, and everybody above 40 45, 50 years old. I'm going to say 45 because I know you're below that.
Thank you.
So yeah, everybody above 45 years old, I will ask them, it's like, how strong is your erection? And if they tell me it's, doc, it's, as strong as a bull, I'm like, okay, on a scale from 1 to 10, 10 being on your honeymoon, what would you give it? Oh, doc, well, it's not going to be the same as it was before. And that's when they start saying, it's like, oh, yeah, it's probably like a 7 or an 8. Okay, so now we're talking that you need an extra push. And that's how usually I start that conversation with them. However, if you have that's basically for every guy who comes into our office. But a guy who comes in specifically for ED, for me, the most important thing to remember, and for everybody who's hearing this, is like we need to remember and understand that these guys come in to see you in a very vulnerable state. And we need to take that into consideration. I mean, these guys basically had a really bad, experience last night. And they made a fool of themselves, and that's the following morning they're going to be looking and calling you. So, for example, here in my office, I have a policy. Everybody who calls in for ED, whenever they ask for an appointment, you're going to give it to them. Why? These guys, if they don't see you right away, if you don't give them the appointment that they want, they're going to go somewhere else and get, to be seen, because they want this fix like ASAP. So that's basically, what I do. I start asking them about everything. It's like from when symptoms occurred, again, how strong is the erection, if they have presence or absence of a curvature, duration of the erection, any change between, when having sex versus when they masturbate. I mean, you want to rule out those psychogenic. I mean, if you have a guy who's 18, 20 years old coming in for ED, it is very likely that it is something psychogenic other than organic. I also start asking them, can they ejaculate? What treatments have they tried before? And have they seen anybody else before? Because again, if you have a guy who's already seen 3 urologists, you want to really go deep into that conversation and find out why he hasn't been able to find the answers like he's been looking for.
And do you usually, start them on Viagra, Cialis, a high dose, or do you try to go low first, see what helps? How long does the process of treating these patients last?
So it actually depends. I mean, has changed. I mean, every year I do something different. Okay. Initially, I would start them on medications, have them follow up in a few weeks, depending on the severity of their ED, or if they have like a lot of comorbidities. I will do a penile Doppler and duplex ultrasound, which will give both us as urologists and also the patient better answers of what's really happening. But now things have changed. So now, I mean, I found out that you can bill for the ultrasound and do it the same day, and it's not going to be bundled to the first patient visit.
Okay. Oh, that's awesome.
So now basically what I do is, again, same thing. You basically take it by ear. If you have a guy who has mild ED, he's like 60-70% without any treatment, it is very likely that pills are going to work. So I'm not going to order an ultrasound for that guy. But if you have a guy who's like, doc, I haven't had sex in 3 years, then that's the guy you're going to be, okay, I can give you the prescriptions, but let's do that test today. Try the medications first, and then you can come back in 2 or 3 weeks and we'll discuss everything. In terms of what dosage I give them, usually I either give them both. Now with GoodRx and compounding pharmacies, you can get these medications very cheap.
It's unbelievable. It doesn't make any sense how other big pharmacies charge $50 for a pill, and GoodRx gives you $20 for 30-day supply.
That's correct.
It doesn't make any sense, but I mean, that's another topic.
So yeah, so usually for those, what I do is I tell them you can either take, you can try both Cialis and Viagra. I have a document that I created here in my office, and I basically describes like all the side effects, how to take the medications. That's the most important thing. I mean, these guys think that these pills are magic, that they take the medication and 5 minutes later they're gonna be like carrying on like a cannon. And I'm like, dude, I mean, you need to be stimulated. So usually what I tell them is, depending on how bad they are, I mean, I either do them full 20 milligrams of Cialis or full 100 milligrams of Viagra, or sometimes I give them, okay, hey, just take the daily tadalafil, 5 milligrams every single day, and on your way out of work, if tonight is going to be your lucky night, You're going to take that 100 milligrams of Viagra on your way to work. That way, you're not timing yourself. You just get home and you can get busy right away.
Okay, that's awesome. So let's talk about the patient that fails medications. They fail the vacuum. They fail everything. So you end up doing a prosthesis. Uh, what type of implant do you use? Do you use what company, what brand? Coloplast, AMS, or Boston Scientific? How do you decide which way to go?
So, I mean, I use both. Both companies hate me for that. I mean, I'm a consultant with both companies. I have great relationships with both territorial managers from both companies here. They actually even get along, which is great for me. I mean, there's no tension here, at least here in my office or in the OR. But yeah, so basically, I use both companies equally. I really don't have a preference between one and the other. I do try to always use a 3-piece as long as I can, unless, the guy doesn't have hands to pump it up. Yeah. But other than that, I mean, I know like there's many surgeons out there who are worried about, for example, a transplant patient who has a pelvic kidney, and they're worried about, injuring it with a reservoir. I try with all my might to be able to get them a 3-piece, just to give them the most natural device that they actually can. Usually, whenever they come in specifically asking for a penile prosthesis, I show them both. I tell them like, hey, this is the AMS, this is the Coloplast. I tell them this is like 2 great cars. Like, you're comparing between a Mercedes and a BMW. You're going to have a great car regardless, but of course they have, their specific features that you really want to know about before you get yourself into this. Most guys are going to ask you, like, oh, but doc, I mean, you're the expert. Which one would you recommend for me? And that's when I start, telling them, it's okay. So if you're younger, sometimes I tend to go with the Coloplast, because again, you want something that will give them like a really, really hard erection. They really don't care of how it feels when it's flaccid. For older guys, I usually go with, Boston Scientific, just because it's easier for them to find that deflate button because of the shape of that pump. And then guys who have, really big phalluses, I try to give them a Coloplast, because again, it's, it has more girth. But I basically just tell them, like, hey man, what do you want? What are you looking for? And depending on what are their goals, that's basically how I go. And that's actually even going back to the previous question, like you asked me, like, how do you evaluate these guys? At the end of the visit, I always ask them, what is your goal? It's like, oh, doc, well, my goal is to be able to satisfy my partner. I'm like, one way or the other. I just want to let you know that one way or the other, we're going to get you there. And whenever they hear that, because again, I mean, most of these guys are hopeless. I mean, they go in here, they come into your office, they're like freaking out. They're like, my wife is going to leave me, or I'm not going to be able to have sex ever again. And what the heck's going on? I mean, I tried pills, pills are not working. What else can I do? And whenever you start showing them their options, they will know that you have their back. So even me, like in their first visit, everybody knows about all the options, and that way I can tell them, like, hey man, you have pills, you have vacuum, you have suppositories, you have the injections.
Trimex, yeah.
So you have the prosthesis, and just in case, don't feel like you have to go through every single step before you reach the prosthetic. If you fail pills, or you're having like really bad side effects from the pills, all the options are open for you. You decide what you want for yourself.
Okay, good. Those are definitely good advices. Technically, in terms of surgery, what approach do you use? You go penoscrotal, infrapubic. What do you do?
So I go 98% penoscrotal. I mean, both approaches are great. I mean, both approaches, have been mastered by now. They both have their pros and cons.
You train both?
So when I was doing my training, I did I was with Ron Wong at MD Anderson and University of Texas here in Houston, and he does mostly penoscrotal. And the good thing for him, I mean, most of what I know, I owe it to him. The guy's a magician operating, and he was very quick and efficient through the penoscrotal approach. And usually that's the big benefit that you get from the infrapubic approach, and that was basically mastered by by Paul Peyronie. I mean, he revolutionized the field since he started, bringing up his infrapubic approach. I mean, he could do the surgery in 15, 20 minutes, and I didn't believe it until I went there and saw it myself, saw it firsthand.
Yeah, it's unbelievable seeing it.
So yeah, I mean,
just put it in, but yeah.
So yeah,
that's the only thing he does.
I know, exactly. So, I mean, the benefits of an infrapubic, for example, I mean, it is a quicker, procedure. You have direct access for the reservoir whenever you're going to place it. The recovery also can be quicker because, again, you're not opening the scrotum. So guys are going to be able to cycle their implant a lot quicker than guys who go through a penoscrotal approach. The reason I go penoscrotal is, again, I mean, I can be just as efficient and quick, with that approach. I'm able to place that pump in a really good dependent position and don't have to worry about high riding pumps or anything like that. And if I go into trouble and there's something else that I need to be done, I can just extend that incision all the way up and do whatever needs to be done. I don't have to make an alternate incision. But again, that's just me. Usually what I tell guys is like, hey, man, I mean, because I have guys coming in all the time to come in and train. They ask me, it's like, hey, which one's better? It's like, there's really not a better one. It's whatever you feel comfortable with.
Good. So, Jonathan, let's talk about some special considerations. Let's talk about a patient with incontinence, urinary incontinence. Are you doing procedures at the same time, or are you just treating first the incontinence? What are you doing with those patients?
So nowadays, it's been actually limited by hospitals more than anything else. I mean, in the past, we were able to do both, but now we all know that whenever you do a procedure and you add an additional procedure to that, the second procedure is only going to be paid, reimbursed only half.
Yeah.
So many surgeons and that, here in our hospitals, they actually don't even allow us to do both, for example, an implant and an AUS at the same time.
Okay.
However, of course, in terms of recovery, it's a little bit better for the patient. They only have to recover once instead of recovering twice. But most of the time, I try to fix the waterworks before I start, fixing the implant. And we try to avoid, doing both unless, I mean, there's actually this new procedure for guys who have minimal incontinence, basically like 1 or 2 pads a day, or guys who are leaking whenever they reach orgasm, which is what we call climacturia. Of course, these are for prostate cancer survivors, or guys who had a TURP, for example, and now they have minimal leakage. There's a procedure called the mini sling, and basically you place a graft right, between the corpus, covering the, you use basically on their corporotomies, you create you place this little graft, and when the patients pump that implant, that graft will basically compress the urethra and won't be able to, doesn't allow the urethra to leak. It actually works very well.
So yeah, so I think the other name is the mini jupette.
The mini jupette, that's right.
So one of our attendants here, one of my partners, he trained with he trained. He's a reconstruction specialist, and definitely he's doing it. I went to see a couple of procedures with him, and it works. It works. So it's something new
and very easy, easy to do.
Exactly. And you can definitely do that at the same time.
And you can actually, and people, I know, like people always ask me about billing for that one. You just bill for a sling, and
that's what he told me. Yeah.
And it gets reimbursed. And again, it's minimal morbidity. You're right there. You don't have to make any additional incisions or anything like that. And you're not burning any bridges. Even if it doesn't work, you can go back there and do a sling,
or whatever,
or doing whatever. Yeah.
So in terms of patients, I mean, you mentioned the patient with kidney transplant. Let's say post-radiation, inguinal surgery. What about ectopic placements? The concealed reservoir. What are your thoughts on that?
I am all about ectopic placement. Like most of my latest research is actually on ectopic placement. If Paul Peyronie listens to this podcast, he's probably going to ding me for it. He hates the word ectopic. Usually what we use is alternative reservoir placement. But anyways, yeah, I mean, post-radiation, I'm really not that concerned. Of course, post radical surgery in the pelvis, post-pelvic surgery, either cystectomy, prostatectomy. Once that retroperitoneal space in the pubic area, in the pelvic area, is compromised, what we want is to avoid that space, right? You don't want to injure anything down there. So usually for those, I mean, the ectopic is definitely recommended. Me personally, all my surgeries, I go alternative, reservoir placement. I go ectopic for all of them, be it the concealed reservoir or even with the coloplast clover leaf. What I usually do, for example, is in order to avoid palpation, I always use the 125 milliliter, basically the large clover leaf reservoir, and I underfill it. And that way that you don't have like a big ball there. Because again, if you use a 75, most implants are going to require somewhere between 50 and 70 cc's. So you're going to have a small ball right there. And palpation is very minimal. And patients really are not really bothered by it. They probably complain about it for about a week, and you just tell them like, hey, you're going to have some, lower abdominal pain for a few days, but they're probably mostly focused on their penile pain.
So that's a great advice. I mean, yeah, I when I have gone ectopic, I never gone bigger, thinking that bigger is gonna be more noticeable. But definitely, if you underinflate it, it should be a nicer in that sense to palpation. So let's say you're doing the procedure, and this happened to me a couple of times already. You're doing the procedure, and it's specific with the coloplast that the pump comes connected to the
cylinders. Yeah.
So sometimes that pump is longer and maybe it doesn't fit on the scrotum. I mean, so it's already open. You don't want to go ahead and open another prosthesis. So have you that happened to you, or have you seen it?
Yes, I mean, there are some guys that have tiny scrotums and really tight scrotums, especially those guys who've been on testosterone for decades. You really have no space to place the pump. I mean, and what I do is the good thing for these devices, they have multiple connectors. So I just, cut the tubing. Okay. And then just reposition it to whatever's good for the patient. I've done that several times. The other thing about that is the way to avoid that is basically trying to avoid the rear tip extenders. The good thing is like now for both companies they have longer tubings. So as long as you have that proximal cord probably, the edge of that proximal cord probably on the bottom is within the single digits. It's like 10 or 10 or centimeters or below. You should have enough length for you to avoid that. You can even avoid using a rear tip. And now we know that the axial rigidity is a lot better in the penis. It feels more natural for them if we avoid those rear tip extenders.
Is there a situation where you go the other way around and actually put extenders instead of just going big?
Yeah, so for guys who are really deep, and I mean, for these obese
they have
guys,
10, 11 down under, and then a little bit outside.
Not even 10, 11. I've had guys who have 15. Like 14, 15. Okay. Yeah. And for those guys, I mean, there's no way you'll be able to do that, to avoid rear tips. So for those, I undersize the cylinder and just add a little bit more rear tip. But again, those situations are rare. Most important thing is that whenever you're doing your dissection, make sure that you go very, very low to do that.
Good. So yeah, I have had patients that come to me and they complain that it's not rigid. I mean, it's rigid, but it's not, obese patient, like you mentioned, but they don't have like the actual erection. That's most likely what happened, that they, instead of just using some extender, they went down and now you have just a little bit coming on the outside and you don't get that extension or that erectile sensation.
Yeah. And for those, there's really not much you can do.
Yeah. So Jonathan, let's say, when it's time to abort, let's say you do a perforation, you're dilating the corpus, you go through the urethra. What do? You just abort? Do you go one side? What do you do?
So, that's a really tough situation. Fortunately, I haven't had a case in which I, dilated through the urethra. First of all, it's trying to avoid that. How do you avoid that? Try to use, whenever you're using dilators, don't use anything smaller than a 9 millimeter. Because anything above a 9 millimeter Brooks or Hagar's is you're asking for trouble. And of course, try to stay lateral whenever you're dilating. usually for those guys who do have a urethral injury, I would either do a single cylinder or just, come back and fight another day. Because again, if you haven't dilated, or if it was just like that initial dilation, I would just abort, come back another day, because otherwise you're just asking yourself for trouble. You don't want a guy who comes in with an infection later on.
So I had this patient, he had Peyronie's disease, so I dilated one side, which was very good. Then the other side, which was actually where he had the curvature, distally, I did a perforation, trying to, with the medicine bond, trying to dilate the area to be able to fit, to go more distal in the glands. So I put in, I was between aborting, I didn't know what to do. I just put one cylinder, and he's doing great, but the expectation is not what he wanted, in the sense that I put a Titan X, the Titan, and he wanted a little bit more girth.
But that's actually that was actually a really good decision on your behalf. You already had dilated one side,
and it was perfect. It was
and
good,
it was good. So for those guys, I would even tell them, like, hey man, you have something, and your case was difficult. You had a lot of fibrosis there. It's like, at least you have a Titan and not not something shorter.
And the rigidity is good. So so he's good. So okay. But still, he wants a little bit more. So we're talking about it. Yeah. So not yet convinced, but we're talking about it.
Yeah, that I can't imagine. Going back there. I've had guys. I remember. I will never forget. I had a guy who he had an implant done by somebody else, and he also had a bladder neck contracture, and they placed the implant without fixing the bladder neck contracture. He comes in to see me. He's like, "Doc, I can't pee." And he has his implant. It was recently placed. It's about 2 months. He had a bladder neck contraction, so I do an incision of the bladder neck. I place a catheter. The issue is, like, the guy had problems with walking, and during his recovery, he had a catheter, and the catheter was basically pulling the leg back on one side for for several days.
Wow.
And then the guy, whenever he wanted, we took the catheter out, he was fine. He went in to have sex with his wife, and boom, it perforated into his urethra. So I told him, like, hey man, now you have it got infected, so we had to take everything out. We'll come back and find another day. He was really eager to get it back, so we went 3 months in to go see him. And I always induce an erection at the beginning of a case. Whenever I placed my needle in order for me to dilate the corpus, and everything just started squirting out from his urethra, and I'm like, man, I'm not gonna go in and place something. So we had to abort 5 minutes into the case. And we went back, basically went until he completed the 6 months after everything, and that's when we were able to place everything. And the guy's doing great now. But it was a good lesson for everyone. It's like, you want to fix the waterworks before you start messing with implants.
So talking about that, you have let's say a young patient, he had accident or diabetes, whatever. Now he's obstructed from the prostate. What are the options?
So, you can do all the options are open for him. I know the important thing is you want to do something that will try to avoid long-term catheterization. So, don't go out doing a suprapubic, prostatectomy that the guy's going to require a catheter for a week or two or whatever. Try to do something that you will be able to take the catheter out, sooner rather than later. For example, you already know this. I do a lot of resumes. I've been able to do resumes for these guys, and they've done well. I haven't had any problems with any of my patients. That being said, doing those resumes, especially guys who have longer penises, sometimes you struggle to get to that bladder neck just because of that prosthesis, because the penis won't compress. So that's something to take into consideration. If you have a guy who has like a really big penis, don't do it in the office while he's awake.
Yeah. Wow.
And then if you are going to do a procedure, my recommendation would be just to avoid, for what I told you about that other guy, to avoid the perforation. You don't want the catheter to be rubbing against the same side all the time. So if they're wearing a leg back, I tell them you're going to alternate every 24 hours. You're going to be alternating the leg back from leg to leg, and that way it's not going to be, rubbing against the same side at all times.
Okay. And do you tell them, hey, there's always a possibility of perforation? I mean, damage to the implant. They have to know. Okay.
Definitely. I mean, yeah, I always undersell and over deliver.
Okay. Good. Yeah, and that's definitely a good advice. I mean, yeah. So let's say, I mean, let's talk about the logistics of prosthetics in terms of uh, after the procedure, how long you take them, you give the antibiotics for how long, when do you see them after the procedure?
Yeah, I mean, of course. I mean, we all know that the most common risk is infection. So I actually start them on an antibiotic the day before the surgery. They take an antibiotic and they continue with the antibiotics for 1 week after the surgery. I think it's voodoo. I think it's all, it's just for me to be able to sleep better at
You
night.
sleep better. Yeah, that's important.
Because whenever they start calling your office, hey doc, I'm still a little bit swollen. I'm like, you're still on antibiotics, so it's not an infection.
Which one you use? What antibiotic?
So I use a fluoroquinolone, I use
Okay.
Levaquin, and a Keflex, and I do a cephalosporin. I've been thinking about going off fluoroquinolones just because of the side effects.
Yeah.
But again, I tell them like, hey, it's just for a few days. If I'm concerned about their joints or anything like that, I give them something else to cover for gram negatives.
And also, I think there's some implanters also that use like a couple of days of antifungal medication.
Yeah, that is
Do,
correct.
do, do you use it you always or just sometimes?
So I do use them for pre-op,
Okay.
and basically pre-op in the operating room. So in the
Okay.
operating room, I give them vancomycin, gentamicin, and diflucan.
Oh, well, okay.
Initially, I was just using diflucan for only diabetics and guys who had coloplasts, just because they don't have the inhibisome from Boston Scientific.
Okay.
But now I just started doing, it's like, hey, just give it to everyone. That way, just to make it easier for for the staff, because they were always asking, it's like, oh, are we getting diflucan or not? I'm like, just put it for everyone. In terms of post-op, I really don't give them that, unless I'm really concerned that they will have it. I haven't been burnt by it before. I've had 2 infections, and they were both bacterial. In terms of the ambulatory procedures, I used to keep everybody overnight. And then after COVID, I actually started
Oh,
discharging
wow. Okay.
everyone. And ever since, I just started doing that. So it's better. I mean, these
Yeah.
guys, believe it or not, Oche, I would say 99% of my implants, they have my personal cell phone number.
Okay. Good.
And that's how I tell them, like, hey man, I'm doing this surgery for you. I'm not gonna throw you under the bus. I'm here for you. Just text, don't call. I have a family, and most of them, I mean, they actually respect that very well. I really don't get bothered much, and I also sleep better at night. I would rather have them contact me than having problems than going somewhere else with somebody who has no idea what to do with them.
And definitely, I mean, that's part of your selling point. Also, they will word of mouth. They will go to other friends. Hey, go to Clavell. He's the guy.
Except when you have a guy who's is crazy,
Yeah, yeah, yeah.
and you're like, I don't want to give you my cell phone.
So, Jonathan, any special bandages after the procedure?
So I do what we call the mummy wrap, but I modify it. The mummy wrap basically goes all the way up to the head of the penis. My mummy wrap basically just covers the scrotum and keeps the penis exposed.
Okay.
And the reason I do that is because I want them to keep that dressing for 48 hours. So I keep that dressing that's basically taking keeping the scrotum under compression for 2 days. They take it out at home at 2 days after they've already processed all the fluids that we gave them in the operating room, and that way I avoid hematomas. We avoid severe scrotal swelling, and they do very well. I actually don't drain. I know that's a big debate, like if we drain or not. I don't leave any drains for these guys, and they do very.
No Foley or anything.
I don't do. I take the Foley out before they wake up.
Okay.
And if they are not able to pee, I put the catheter back in, and they can just take it out at home. And most of the time, we just teach them, it's like, just take it out early in the morning, and you'll be fine.
So I've been doing the mummy wrap of the scrotum, and that definitely, I think you can start cycling the pump earlier, or at least you're able to touch the scrotum earlier.
That is correct.
And tell them to just move it forward, and just try to keep it closer to the skin.
Mhm.
When do you see the patients afterwards?
So I usually see my patients at 6 weeks, I did that during fellowship. My partner, for example, he also does a ton of implants. And initially, I was seeing his patients when I started early on, and he had his patients come back at 4 weeks. If you go penoscrotal, sometimes they will still be sore at 4 weeks. So that's why I tell them, like, hey man, go at 6 weeks. And they have my cell phone, so I just tell them, like, hey, if you feel great by 4 or 5 weeks, just shoot me a picture of your incision. If the incision looks fine and you feel comfortable cycling the implant, just go ahead and cycle. And the good thing is, like, I was able to create a really good video on how to best inflate and deflate both devices, both the AMS and the coloplast. So for everyone who's listening to us,
that's on your YouTube channel.
It's in my YouTube channels.
Okay.
It's actually my 2 latest videos. And yeah, it's a great resource. It's saved a lot of conversations with patients.
You can go to YouTube and just Google Jonathan Clavell.
That's right. You just put my name, Jonathan Clavell, Clavell, and you'll be able to find basically most of my work. I've had colleagues telling me, like, hey, don't put your videos like that. You're basically spilling out all your secrets. And again, that's the way that I show patients, like, hey, this is how I do it, and this is what you're going to get yourself into, and they know. And it's actually even brought more patients in to see me.
That's awesome. So definitely, I'll look into them. I have seen a few, but I need to know the one for the cycling. Started cycling the patient. So after 6 weeks, you see them. They start cycling. How long does it take prior to start using it?
So I usually start, at 6 weeks, I tell them, like, hey, you're good to use it. Usually by 4 or 5 weeks, they should be okay. I wouldn't, for those that do infrapubic, that guys are able to cycle it a lot sooner, like 2 or 3 weeks. I know there are docs that, they as soon as you can start cycling, they allow them to have sex. I don't encourage that because, again, I want those core parottomies to hold well. And I don't want a core parotome to burst open. I've actually seen, not my patient, but I've seen patients who started having sex beforehand, and the core parotome opened up, and the cylinder just slipped right through that core parotome. So, and again, it wasn't my patient, but it's actually a really cool video that I actually have to post at some point.
Okay. and do you leave the cylinder a little bit full or completely?
Yeah, so all my patients they're about 70% inflated. I want, after post-op, and I leave.
It's gonna be like that for 6 weeks.
I tell them it's gonna, especially whenever you have a thin guy who has a big penis, I tell them your recovery is gonna suck, but in a good way. And of course, if by 2 or 3 weeks they feel like doc, I just can't take it, then I tell them, like, hey, you can start cycling if you feel comfortable doing it. They can start cycling up to 6 weeks, and then at 5 or 6 weeks, that's when I tell them, like, hey, you can start having sex.
Good. So I usually go 4 weeks. I tell them to start using it, cycling it a couple of minutes a day for 2 or 3 weeks, and then it will be more or less from 6 to 8 weeks start using it. Usually diabetics, they tend to be a little bit longer, depending on how their glucose is. Do you do an A1C prior to surgery for diabetics?
Yes, I do, and it's just so that I have an idea. I really don't have a cutoff for them to undergo surgery. The most important thing is that they are compliant with their medications. For example, if you have a guy who his last A1C, 3 months ago it was 8 and now it's 10, that's not a guy you want to take into the operating room. There was actually even there's been recent studies showing that the pre-op glucose is actually more important than the hemoglobin A1C. So it's very important that you have them at least seeing an endocrinologist or seeing their primary care doctor, and you have to tell them, like, hey man, I did my part. Now it's on you. If you get infected, it's because of you. I did this and this and this and that to avoid infections. If you get infected, it's all on you. And that way, by giving them responsibility, they tend to respond a little bit better.
And do you have any cutoff for that patient in pre-op? Let's say if it's in 400, would you still go ahead?
To be honest, I don't even ask.
Okay.
I mean, of course, if if anesthesia calls you, hey,
Exactly.
this guy's at 350, I will ask him, okay, if is he insulin dependent? If he's insulin dependent, I will still proceed. I just tell him like, hey man, make sure. I mean, because again, they come in without even eating or anything like that, so they haven't used their medications. So, I mean, it's hard, man. That was a tough decision.
No, I mean, yeah, but I mean, as long as they're aware, you speak to them, communication, and like you said, I mean, give them some responsibility in that part. And you take, I mean, do you do anything different in terms of the antibiotic for those patients?
Not really. Not really. I mean, of course, for those, I really want to use diflucan for sure. So I make sure that they have, that they have their antibiotics. The vancomycin, I want it completely like 100% in before I make my incision. But other than that, I mean, I just take him out on the fly. I mean, for example, one of the infections that I had, the last one actually that I had, he was a diabetic, but he decided that he didn't want to take his medications because he could control it with diet. And he came in every morning, his glucose was 400. And he's like, Doc, sorry. In the morning, it was like 180 or something. He's like, oh, no, Doc, I'm below 200. I'm like, yeah, but you eat breakfast and that's 400 for the rest of the day. And that guy got infected. And I told him, like, hey, man, I mean, I told you. But in terms of, A1Cs, I mean, I've done, 10, 11s and they do fairly well. 12, 13. I would encourage them to wait a little bit longer.
Do you see any difference in terms of pain afterwards with those patients?
It's actually a great question, and I haven't looked into that. It's a good question.
I mean, it's, some patients with neuropathy, I mean, they're more sensitive. After you do any intervention, they continue to complain of that urethral persistent pain. So I don't know if I mean, I haven't looked into it, but definitely it's a good thing to look into to see if there's a difference in terms of pain medication afterwards.
That said, I mean, all my patients, I give them gabapentin post-op. So
for how long?
So I give them. So my post-op regimen is meloxicam, gabapentin. Meloxicam, I give them for 2 weeks. I don't want them to be longer than 2 weeks just to avoid, kidney damage. But the gabapentin, I usually tell them that's your go-to, and Tylenol. And then I also give them tramadol for breakthrough. But most patients, they don't need it because the other thing that one of the hospitals that I'm doing my surgeries, they allow me to use Exparel.
Exactly, yeah.
And man, I mean, that Exparel does wonders.
Are you injecting in the corpus prior to the procedure?
Yes. So I do a full block, and I also do intracavernosal injection. I induce an erection to all my patients. I just do so many Peyronie's cases that I don't want any surprises. So I basically induce everybody with the Exparel. So
when you're doing the erection, I mean the artificial erection, you're using Exparel at that moment?
That's right. I combine Exparel with saline. I tell anesthesia, it's like, hey, you're going to have some changes in your EKG. Don't freak out. And I haven't had any issues.
And I think, that using that is the key to just not giving Percocet or anything more stronger.
Definitely.
I was doing it before, but now the hospital, they let me doing the using it, and yeah, it's a game changer in that sense.
Yeah, I've only prescribed narcotics twice since I started practice. And the only patients that needed it were guys who were already taking narcotics for chronic back pain issues, so their pain tolerance was very low. And for those, I told them, like, hey man, I'll just give it to you. But again, most of the time they don't need it.
Good. So Jonathan, we'll continue to talk about other cases. I mean, the long-term complications, andrology, resume, other special considerations. Any other suggestion or anything you want to say in terms of that initial evaluation or that initial first implant procedure?
I mean, again, the most important thing is just remember that these guys are very vulnerable. They are hopeless. They are just looking for answers for somebody who can actually listen to them. The other thing that I would, make sure is like if they have a partner who supports them, try to involve them in the conversation, because these guys are gonna leave your office like super pumped. They're super happy and excited that they're gonna have a solution, and then they go home. Their partner asks them, like, "Hey, so what did the doctor say?" And then they don't remember anything that you told them. And then it's like, "Oh yeah, he talked about pills, and if not pills, we're gonna have some implant that we can use, and I'm gonna be able to use it at any time that I want." And the partner's like gonna be like, "What the heck are you guys talking about?" So always try to involve the partner in these conversations. It's gonna go a long way. It's gonna even save you a lot of long conversations. Again, you have this conversation for 30 minutes, and then the partner comes back and you have to repeat the exact same conversation so the partner can now understand. So I always encourage them, it's like, hey, if your partner's in the waiting area, because most of the time they're in the waiting area, it's like, bring them along. It's like, oh, COVID restriction, I don't care. Bring them in. They can wear a mask, and we can go both sit down and talk.
And for those patients that go to the office, the first time, do you have videos? You play videos for them while they're waiting in the room while you're seeing other patients?
So I don't. The only ones that I use videos for are actually for resume patients. Okay. Whenever I do the cysto, I tell them, hey, get dressed, watch this video, and actually it gives me time to see another patient while they're looking at the video.
Yeah. So I use those two. I use the green light for Eurolift. Those guys are great. The reps are great giving us those small video boxes. Yeah. So that's good, but definitely, there should be something for ED. It will be better for us, easier to explain the procedure. Maybe take a little bit of time from our part.
There are videos. I know Boston Scientific definitely has a video that you can show them. But again, I wouldn't give that video on the first visit. They're gonna freak out if the first thing exactly. Before you even see them, it's like, oh yeah, you need a surgery.
True, that's true. So Jonathan, thanks for being here in BackTable. We'll definitely looking forward to see you again and talk to about other things that you do, like andrology, the resume, other stuff, and complications. You're going to talk about sexual medicine in the conference about the complications. So that's definitely one talk that we're going to do afterwards. The long-term
definitely, man. Again, it's an honor. It's a pleasure. Even if you even want to talk about Peyronie's, I know that's a big. Usually, I remember I gave up last year. Actually, no, 2 years ago. They invited me to give a presentation on the complications after Siaflex and Peyronie surgery. It was close to. It's actually a funny story. It was close to Halloween, so it was like October 20 something. And my first slide, it was like a big curved penis. I'm like, fear the penis. It's like if there's one condition that most urologists fear, it's actually Peyronie's disease.
And now they're actually there's advertisement for that. Before you didn't saw it in the news on the TV, so that's something that and you see it more. When you ask about curvature, a lot of men have it. Most of the time, just subclinical, but definitely very important to ask and be aware of it.
Definitely. Now the word is out. You can. Even in a Sirius XM, I always listen to that on my way to the office and out of the office, listening to sports, and all you can hear is like beatthecurve.com and da 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 da. So yeah, those patients are definitely going to come in and they're going to be asking for help. And again, invite me here once again. I love doing this. So
we will. So good to have you, and we'll definitely talk some more another time.
Awesome, man. Well, thank you, and you have a great day, man.
You too. Take care.